My name is Barbara Cochran. I'm the director of the DeTournay Center for Healthy Aging here in the School of Nursing, and today, as often, I'm representing the Northwest Geriatrics Workforce Enhancement Center, which is sponsoring this series of geriatric healthcare lectures. This term, spring term, the focus is on Alzheimer's disease and related dementias, and so we have a series of lectures, actually thanks to the assistance of Dr. Thielke here, who have identified topics for this term. Just a reminder to contact your site coordinators if you have not completed a profile form for this particular series. This is the way that we keep track of who's participating, or at least numbers of who are participating, so that we can report that off to our funding agency and continue to fund this lecture series. If you want to get continuing education contact hours, your site coordinator also has the information that you can use to go online and register for the series for contact hours. I think it's at like a $45 charge for setup for the series for this term, and then you just essentially log in for the lectures that you have attended. Another thing I wanted to mention is that these lectures are posted on our center's website, and I'll put that into the chat box again, but it's nwgwec.org, and those lectures are posted within about 48 to 72 hours of their presentation on that website under Geriatric Healthcare Lecture Series. Today, I'm very happy to introduce Stephen Thielke. He's a geriatric psychiatrist and health services researcher here at the University of Washington, as well as at the Puget Sound VA Geriatric Research Education and Clinical Center, fondly known as the GREC.
The GREC.
He's actually the GREC Associate Director for Education and Evaluation. He also conducts research about dementia medications, depression, and pain in older adults, and the use of monitoring technology in healthcare. So I guess I'll say take it away, Dr. Thielke.
Hey, well, thanks, Barb. I'm really glad to be here. And thank you all very much for calling in today. I've never talked about this topic before, and in getting the talk ready, I realized just how much I really care about this topic, and am glad to be given the opportunity to talk about it. The initial version that I had prepared was kind of dry and along the lines of a lot of talks that you see about medications for dementia, which is sort of how to and what the best choices are. And then I stepped back and realized that the key issues in medication use really are much bigger. And I'm going to present more of a strong case or argument about the dangers of medication, and I'll just make that clear up front. So I understand that this is probably a different type of approach than you may have heard before, and I hope it can encourage some discussion. So what I wanted to do in order to address this is, first of all, to consider a very general question about any kind of medication, like what's a medication supposed to do for anybody taking it for any condition, and then to look specifically at dementia and talk about why medications are difficult to understand and to use rationally in dementia. Then to consider how we could use medications to make sure that everyone has an overall benefit from their use. And I realize that a lot of us don't prescribe medications, but I want to address the probably most important question of how we can all work together to ensure that our patients with dementia are receiving treatments that are safe and effective for them. And I really believe that this is a team effort, and that even if you're not signing the prescription, your input and observations and permission can be very important and, in fact, essential for making the process work in the right way. So I want to start with the bottom line here. Really, when I spend a lot of my time looking at medications for dementia, and talking to people about them, and reviewing other literature. And I really believe that there is a reasonable scientific and ethical case for avoiding medications in dementia. And if people are taking medications for dementia for a while, there's an ethical case for stopping them, or trying stopping them, and to really focus our attention instead on behavioral interventions and caregiver supports. I'm guessing that this has become a clear theme throughout this series. And in terms of what we can do practically, all of us can let patients and families know that they don't have to be taking a medication. I'm not saying they should or shouldn't, but I do believe that they should know that that's an option, and that really, most importantly, the decision about medication use should be the patients and the caregivers. And really, that's the crux of this, that we need to make sure that patients and caregivers and family members understand what the real potential risks and benefits are of medications, in particular the real risks, and that when the rubber hits the road, that it's their decision and not the decision of someone else as to whether they should or shouldn't be taking a medication. So briefly, even more briefly, there's no right or wrong about whether people should or shouldn't be using any specific types of medications for dementia. Instead, people should be making their own decisions, and they should be fully informed about them. So I want to address first this question of what medications accomplish in general. And if you really stop to think about it, it's a kind of a tricky question. Like, people take pills. You go to your provider, tell them some kind of symptoms, or they do some kind of tests, and you walk out the door with a pill, and you say, oh, I'm supposed to take this pill. But you usually don't break it down into categories and say, what exactly am I supposed to get out of using this pill? So this is a rough framework. I think it's worthwhile to think about what some of the goals are that you might want to accomplish. And the most obvious is if you've got something that's bugging you, like if you're itchy or you're in pain, or you have something that doesn't work in your body, or your mood is bad, or you're anxious, or you're hearing voices or something, and that's unpleasant to you. Potentially there's medications that could improve that, make it better, and so you would know by taking it if that's having a desired effect. That's a lot of medications. It's roughly the category of symptom control. You also have medications that don't directly have any effect on how you feel, but they're supposed to stop your disease from getting worse. So taking a pill for your cholesterol, I've never heard of anybody who could feel what their cholesterol level was. So you go to the doctor, they test your cholesterol, they say, your cholesterol is 250, it's supposed to be 200, take this pill and we'll get it down there, and you'll be happy ever after. Just as an aside, unfortunately, a lot of the expectations about what's good and bad for your health in terms of cholesterol levels and blood pressure and blood sugar levels don't hold as you get older. So if you're in the field of geriatrics, you got to stop and ask, is it really something I want to accomplish to lower the cholesterol level to a level that somebody said was healthy for a 30-year-old? But anyways, this class of medications is supposed to stop things from getting worse. Then there's also medications that are supposed to improve your functioning. Performance enhancement is not really the right term for it, but if you have some difficulties carrying things out and you take a pill and you're able to do them better, then you'd say there was a motivation for using a medication that way. The simplest example I thought of was somebody's got attention deficit disorder and they take Ritalin or a stimulant for it and they're able to focus better. You'd assume that that's a reasonable outcome. And then along with the category of preventing or disease or stopping it from getting worse, there's some pills that are just supposed to help you live longer. So all the research about like taking a baby aspirin which really doesn't necessarily treat a particular condition, although you may say it might prevent cardiovascular disease. But when they run the numbers and decide, people who take this agent or have this blood level live longer, the goal is simply to make you live longer. So if I'm missing anything, please let me know. But I think this roughly, explains what we're trying to accomplish. And I hope you'll come to see why this is important in the setting of dementia and why it's so tricky to apply these categories to a condition like dementia. And if you're in this setting and you're being a reasonable person, after you start a treatment, you can tell if it's worthwhile, because you're measuring something, how itchy you are. You take a pill. If you're less itchy, then you follow the green line. You'd say, hey, this thing works great, I'm going to keep using it. If you're about the same, the yellow line, you'd say, I don't know, maybe it's doing nothing. And if you're worse, like the blue line, you'd say, this pill is not having an overall benefit. So simply on the principle of observation, you can tell if it's doing something or not. Obviously, this is a little trickier if your goal is to extend your lifespan, because the only way you would know is to wait and measure how long it took until you died, which is usually not the best approach for determining if a pill worked for you. But for the most part, we assume that you can tell if something helped or not, for instance, by measuring your lab values or something else that you care about. If you step back a sec, you realize there are some problems with this. First of all is the problem with how pills mainly get used, which is the pill for every ill model, where it's assumed that if you've got a condition, you got to be taking a pill for it. You got diabetes, therefore you need to be on diabetes medication. You've got hypertension, you got to be on an antihypertensive. Your cholesterol's high, you got to be on cholesterol. You got depression, you got to take an antidepressant. And this is kind of the very simplistic, if condition, then treatment. And this is what guidelines encourage. And people can argue that, if you follow the guidelines, everybody does better. But it really loses track of the whole idea that you should be getting something out of the pills that you take instead of just taking them because somebody says so. And the reason for this is that there's always a cost to taking a pill. This is both a monetary cost, buying it, or having somebody else buy it, and then the act of taking a pill every day. And then there are real risks or side effects, and we'll talk about that in the setting of dementia. And if there was a trade-off between the goals, or the accomplishing the goals, and the costs and risks, who gets to say what the right answer is? So is it the provider who knows best and tells you, if I were you, I'd take this cholesterol pill, even though it's causing you some leg pain? Or is it the patient who gets to say what the cost and benefit balance is? So it's not an easy question, and if you try to reconstruct this in a scientific or systematic way, and you ask people, questions like, you've got this symptom, how much would you pay to get rid of it? Or how much would a pill cost? You get a very wide range of answers. And it definitely depends on a lot of circumstances. And that's a monetary value where it has some meaning. If you're tying it to a side effect, if somebody's going to have gastrointestinal upset and no itching, but itching and gastrointestinal upset, it's a very difficult balance to make. So this is just to suggest that there's no perfect pill, and that it's always a decision based on a balance of risks and benefits, and we assume that people are logical agents. Now we get to the main problem in dementia, and this is like a core fundamental problem, and really if you take one thing away from this talk, I hope it's this, that dementia is a deteriorating condition. We've talked about this initially about dementia. You've heard it many times. By its definition, dementia is going to get worse, which means that you cannot apply this logic to your treatments. You can't say, well, if it's worse, therefore the pill is not having a benefit. And you're really not going to get an overall improvement because that's not how the condition is. There's no case of dementia to date that has ever been cured. Some were misdiagnosed, but it's going to get worse and worse. So what that means is that you have a moving target with dementia, and any pills you use in the setting of dementia can't be tied specifically to a change that can be demonstrated by reason or logic. And it basically gives you an excuse for saying anything at all about the effect of medications. So if somebody's got dementia, they're in this blue window of getting worse. Let's say they follow that red line. They're worse after a period of years on a medication. You can always say to yourself, hey, yeah, they are worse, but think just how much worse they would have been if they hadn't been taking that medication. And this is just a logical trap. There's no way out of it. There's no way to relive the experience without a medication, and it's something that we're stuck with. And I'm going to come back to this point again and again, but I think it really is worth acknowledging. And when I talk to families and patients about this, they will recognize it, and it's not like a mystery to them. They'll say, yeah, he's been taking the pill, and his conditions now, I don't know what he would have been like. And you can spin it either way. You can say, well, they would have been better, or they would have been worse, or it didn't make a difference. But it's very difficult without a known trajectory to know how much a medication budged you one way or the other. The other problem with dementia is that while the overall course is getting worse and worse, the symptoms of the disease fluctuate over time. And this is clear in study after study. 70% of dementia patients have some behavioral symptoms at some time during the disease, but that does not mean that they develop behavioral symptoms and then have those forever until they die, or that they have them and they continue to worsen. In fact, my experience is that most problematic symptoms in dementia are somewhat transitory, that they come on, they get worse, and then over time they get better. And my explanation for this, that I think makes some sense, is that as you're deteriorating functionally and cognitively in dementia, your awareness that things aren't right diminishes or declines. So somebody's cognitively connected, capable, and they're aware of their circumstances, and they can make reasonable judgments about it, and the world makes sense, they're unlikely to get agitated and upset. If, however, they're still aware of what's going on, but not completely, and this makes them upset, that's when you're bound to have problems. For instance, somebody is at home and they can't find their wallet, and one of their children was over, or a caregiver was over. It's only logical to assume that if the wallet was there, somebody was here, the wallet is gone, therefore somebody stole the wallet, and you're going to get upset, and you're going to say, who took my stuff? Even though you don't remember that you're the one who put it away, or that your son or daughter said, I'm taking your wallet and putting it in the drawer. So that's the type of setting where somebody would get upset or distressed, or if their sleep-wake cycle is off and they get up at night and are confused, that's when they would wander off. Later into the disease, however, people tend to become less distressed. I know this is a generalization, but I think it is generally true that as people are less aware of all the details going on around them, they become less worried that something is broken, or that there's a gap between how things are and how they should be. So the wallet's not there, but you don't even realize you need to be keeping track of the wallet. So what this means is that as people go through different stages of dementia, they may have different symptoms, and sometimes these peak at a certain time and then naturally decline. But if you're using a medication to try to treat those, you really can't expect there to be a predictable response, nor if there's a change, can you attribute it to the medication itself. So if the symptoms are just getting worse because of the disease progression, say at the green point or the gray point, and you start a medication and nothing changes, well, maybe it was having an effect because things are better than they would have been. If, however, you start one at the blue point or the red point and you say, hey, things are better, this is great, this is like a miracle pill, it may in fact have nothing to do with the medication itself and everything to do with the resolution of symptoms. So once again, the problem of the moving target really makes it difficult to establish in a general way for any individual if a medication was helping them. That's not to say that there aren't cases, which we run across very often where somebody takes a pill, their caregiver says, oh, things are a lot better, and then if you stop it, their symptoms return. But that as a general proposition, it's very difficult to know if it's the medication that's having an effect. All right, so that I hope you will forgive me the general background, but I really wanted to hone in on that challenge with dementia and to point out this fundamental logical problem with figuring out what medications do when you're dealing with a condition that's deteriorating and fluctuating. So what I want to do is talk about the three main classes of medication that are used in dementia. First of all is medications specifically to treat dementia, kind of typically or colloquially known as memory pills. The second one is the pills to treat the behavioral symptoms of dementia. And then the last is other psychiatric medications, especially antidepressants. So I'm sure you all know that there's pills on the market for dementia. However, there are no pills that improve memory on their own. These medications work by increasing neurotransmitters that can have some effect on cognition, but in terms of enhancing memory, we don't actually have medications like that. So it's not like if somebody who doesn't have dementia took one of these pills, suddenly they would have a better recollection of what happened yesterday, 2 days ago, on their 5th birthday, anything like that. Memory is a very complicated cognitive process. We don't fully know how it works, and clearly it's not just like your ability to remember stuff depends on the level of a certain chemical in your brain. So the whole idea of a memory pill really is off. Instead, what these medications are doing is providing a certain degree of cognitive enhancement. And these pills that have been approved by the FDA fall into two categories. One are cholinesterase inhibitors, and those increase levels of acetylcholine in the brain. That's a neurotransmitter that's involved in attention and cognition, as well as a variety of other things in the brain, and also it has effects in the body, and that's explains some of the side effects. And then memantine, which is NMDA antagonist. So this is a part of the neurotransmitter system we don't talk about much that involves glutamate transmission. Frankly, nobody fully knows how it works, but I'll give you some evidence about what it does, and it's really not very much. But neither of these actually change memory itself. What they've been approved for instead are cognitive outcomes, so people's ability to carry out cognitive tests, and we'll see the degree to which they do that. I want to give you the actual evidence, but they are, most importantly, not a cure. They don't fix dementia, they don't fix memory problems long term. They're in fact nothing at all like a cure because the disease progresses. And I think this will become very clear as we look at some of the evidence that has been developed around the course of dementia when people do or don't take these medications. So it's not like any other condition that you might, if you have hypertension and you take antihypertensives, you'd say, well, your blood pressure is regular now and you're not at risk. Or if you had cancer and you got treated with surgery and radiation or some other form of curative treatment, and they tell you you're cured of this disease. Dementia is simply not like that. There is no cure that we have for the condition, and the medications that we use should not even be considered in the class of a cure-at-all. Instead, what they provide is some symptomatic benefit. Even worse news for those of us who don't have dementia is there's no pills that are known to prevent dementia. This has been the subject of a great deal of study. This is a little cover of the NIH consensus report on preventing Alzheimer's disease. The bottom line is there's no medications that have been demonstrated to prevent dementia, really no other interventions that are demonstrated to prevent dementia. And there's also no medications that are approved to treat mild cognitive problems. So more reminder that the problem is not something that we can fix with a pill, either to prevent it or to treat it or to cure it. And instead, what we're hoping for with medications is some symptomatic control. So I want to provide the actual outcomes from what is to date the largest trial of dementia medications. And importantly, this was done in the UK, paid for by the British government. It's not a drug company study. They were very careful not to involve commercial influences. It's called the AD 2000 study, if you want to look it up. Very, very carefully done, and they measured a variety of outcomes. So that you can tell they went to a little over 2 years, about 110 weeks that they followed people, which is also a lot longer than other studies. And when you look at the changes between the groups, if you compare the treatment group, which is the black dots, to the placebo group, which is the white dots, on average, what people are getting on the drug treatment, the donepezil, is about 0.8 points on a 30-point scale. So the bottom one there is mini-mental. You get about 0.8 points. And that's enough to show a statistically significant difference with a large group of people, but the logical question that I hope you're asking yourself is, what would that really be worth? It's 30 points, 0.8 of a point. Like, how much would you pay to have 0.8 of a point? And maybe there's situations where that would be great, but what's it really worth? And likewise, very similar result in the upper graph on a basic ADL scale. This was a 17-point scale, and you got about 1 ADL. Once again, enough to show a difference statistically, but how much are you really getting in terms of benefit for the patient and caregiver? What you'll notice about the long time scale too is that the lines don't converge completely, they don't cross, but the dramatic effects definitely aren't there after a while, and even they're not even there to begin with. But if you only showed the data, say, up to 36 weeks, it would look like there's more of a separation between lines, when really what you're getting is a marginal slight difference in the cognitive status and the ADL scales across time. So once again, it's very important to track this long term. And then the next reasonable question after what's this worth, 0.8 points or 1 point, would be, what about outcomes that might matter to people, like behavioral, psychological problems, the caregiver's degree of distress, how much money it cost, how much time it took to care for the person with dementia, whether lifespan changed. And when they looked at all of these outcomes, there was no difference between people treated and people who were not treated. And this is a graph of the time to loss of activities of daily living. So this is when people were no longer able to carry out their ADLs. So even though there was a 1 point difference, when you really looked at the cumulative effect on the person's life, there really was essentially no difference at all between those who were treated and those who were not. So this would make you step back and say, I may be getting a little cognitive benefit on a test they administered and maybe a little bit of basic ADL benefit, but does this matter to me or my family? This is a nice summary of the studies that have been done. Published in the British Medical Journal, very respectable journal. They did a very careful job of analyzing the studies. And their background, which was largely pharmaceutical research, is that randomized controlled studies suggested there was a beneficial effect of these medications. And there were a lot of reviews done. But when they did their careful systematic review, they found that the recommendations for using these medications were not evidence-based, that the benefit scales, benefits measured on the rating scales were minimal at best, and that the quality of the studies was poor. So people who really thought carefully about this data ended up concluding that there wasn't really a strong reason for using these medications. I want to talk quickly about memantine and then provide a big overview of these memory pills. So this is the largest study of memantine to date that got it approved by the FDA. And they broke people down by category. And when I look at this slide, the two groups look pretty much totally identical. You know, maybe there's a little bit more percentage of people who had no change in the memantine group and a little bit more worsening in the placebo group. But if you were going to play darts on this or bet your money somewhere, you would not make very much money betting on memantine, for especially if your hope was for improvement. So this drug got approved based on some studies. It's had some evidence in other studies, but overall the benefit is minimal. When we did a big multi-site VA study looking at memantine and vitamin E, we found that it had very little overall effect. Vitamin E had more of an effect than did memantine. So once again, definitely not a cure. So this is an overview of dementia medications that I think very succinctly and accurately describes what these medications are and do. That even though there's statistical improvements in the analyses, if you do the studies and you pick the measures that you want to assess, they do not necessarily translate into clinically relevant benefits for the patients receiving these drugs or for their caregivers. So that's pretty strong message. It doesn't mean that there's not benefits in some cases. Certainly, there are people who say they have helped them, and if you look at this graph, there's some people who seem to do better on a treatment. But in terms of an overall guaranteed marginal benefit, there's not strong evidence. So the question from Sheridan about the VA study, the graph is not a VA study, but the other one I mentioned, the multi-site study, was a VA study, and the author of that is Maurice Dysken, D-Y-S-K-E-N, if you happen to be interested in looking it up. The finding about vitamin E was interesting also. Also, I had a comment from Wolf Point, somebody who thought that they did, her mother did as well on ginkgo, and price through the roof. Great point about price. I'm going to bring up the actual amount of sales of memantine in a few minutes. So it's a lot of money. Yeah, definitely an important factor. Oh, here it is. Next slide. Yeah, so it's hard to say exactly what the costs are. The costs used to be higher because these medications were not generic. Even though they're generic, they're still pretty pricey. When Namenda was brand name still in 2014, the cost for patients was about $300 a month. And the sales in 2014 were $1.8 billion. So that's just, it's jaw-dropping. If you were curing a childhood cancer, you might say, oh yeah, this is really worth it. But if a lot of the people taking it really had very little benefit, you got to ask yourself what the point was. As Barb was announcing the series here, say that it costs $45 to participate. I was doing the math, if At $45, how many memberships to the NWGC series could you get for $1.8 billion? I don't know. Probably the whole U.S. population could get CE credits for this. So it's a lot of money, clearly. So I want to talk quickly about side effects and risks. And the side effects you probably know about, mainly related to stomach upset. Sometimes they can lower your heart rate, worsen lung secretions. There's some unexpected effects that can happen. So if you know somebody taking these, you could be on the lookout. When we did this VA study, I was one of the clinicians who would talk to people, and we got some bizarre findings on memantine, like a guy who insisted on seeing his wife's grave. Like he just got fixated on that, but she had been cremated. So he couldn't get this into his head that this had happened. And this only came on after he started the memantine. When he stopped it, it went away. And then the same fixed delusion came back after he restarted it. Another person in the study had very significant behavioral changes socially, like had been a pretty quiet guy, and after he started the medication just wouldn't stop talking to strangers. So it can have unexpected effects. Most of the effects tend to be transitory, so it's not a medication that's difficult to tolerate. But there are known risks that have become clearer and clearer over time. These were not things that I learned about when I was going through training, a decade or so ago. But in the last 4 or 5 years, there have been a lot of publications indicating that cholinesterase inhibitors, so donepezil, galantamine, and rivastigmine, have significant risks. So this includes the risk of significant weight loss, which they measured as 10 pounds or more. The risk of falls and hospitalizations was higher. People are at risk for starting medications to treat urinary overflow. So somebody would be started on a cholinesterase inhibitor, have urinary symptoms, then be started on an anticholinergic medication, which then basically counteracts the effects of the dementia medication. So it's this spiral that blocks out any potential benefits from either. The risk of being on a bunch of medications and having drug interactions was increased when people were on cholinesterase inhibitors. And then the finding of depression. This is very interesting. I doubt you've heard about it before. Most of the people I talk to, even in the field of dementia, haven't come across this risk. But when we started looking for it in our clinic and asking about it, we certainly see it a lot. And I want to show you the actual study because it's an interesting case study of how a risk, a long-term side effect, can go unnoticed. So this is a study done by Chip Reynolds, who's a geriatric psychiatrist at the University of Pittsburgh. And he and his group started thinking that maybe people who were developing dementia and had a history of depression would do better if they got a cognitive enhancing medication, which would make some sense because you can't remember, you can't think very well. That's probably going to worsen your mood. So then you get a pill that helps you think clearer, you remember more. Suddenly you're able to be more active and do your activities. So they convinced a pharmaceutical company to fund a study where they took people who had a history of depression and treated them with donepezil or a placebo. Some of them had no cognitive impairment and some of them had an early form of dementia. So this was a randomized study, and what they expected to see was that the people who had treatment with donepezil would have a better mood outcome. And so to their surprise, great amazement, and I still am surprised every time I think about this, it was exactly the opposite. So the people who got donepezil had a far higher rate of depression recurrence. You can see that in the upper right graph. So staying high on the graph is good. That means your depression did not recur, and the lower you go, the more likely your depression was to recur. And you can see the dotted line there. The placebo group had a rate of depression recurrence about 80, 85% did not recur, whereas in the donepezil group, it was about 65% did not recur. So people who got a cholinesterase inhibitor were statistically more likely and pretty, importantly, more likely to have a worsening in depression. And it seemed to apply more, as you can see on the bottom, to people who had mild cognitive impairment than people who had normal cognition, but the effect was in both groups. So this means that if somebody's taking one of these dementia medications, you sort of should be on the lookout for their mood bottoming out. And this is what we see in clinic when we really ask people, how's your mood been since you started it? A lot of times they won't mention it, but their caregiver or spouse will say, oh yeah, it seems like he's just kind of more bummed out. So I talked to Sue Borson about this, old-time geriatric psychiatrist who's now retired, and she said, oh yeah, this makes perfect sense. There used to be this hypothesis about the acetylcholine system and depression, and that if you overactivated it, people would become depressed. So this one might make sense, but it's a good example of how you can have an effect that nobody picked up on. In all the initial studies that were done, nobody bothered to measure this carefully, and when somebody did, they found that sure enough, it's a real risk. And I think the reason partly for this is back to that conundrum of the moving target. If you've got a condition that's bound to get worse, you can always say that a problem is due to the disease. Well, yeah, he's worse, but he's got dementia. And so you don't usually think back carefully about when the medication was started, or are able to think back that far if it's a delayed effect. So people don't tend to blame problems in the setting of dementia on the treatments, and instead they blame the problems on the disease. And in order to expose these risks like weight loss, hospitalization, falls, polypharmacy, depression, you need to carry out careful retrospective studies or careful placebo-controlled studies, which can be quite difficult to do. So it's taken time and effort to figure out what these risks are, but over time it's become clearer that they're there. These are not entirely safe pills. So I think that the logical take-home that you can figure out from that is that if people are taking these, you need to have a discussion with them about the real risks. It's not good to say, oh, here's your pill for dementia, it's harmless, it may help you, good luck to you. Instead, you need to narrow in on what the benefits and risks are and what people should be looking out for if they're taking them. All right, so that's a brief overview of the existing drugs for dementia. I want to spend a little time on this topic, which is certainly somewhat depressing, but is important to know because people will ask questions, and it gives you a sense of the science around this. So there's a lot of drugs that have been tried for Alzheimer's. Haven't kept track of them, but it's easily in the dozens or maybe up to 100. No new drugs have been approved in the last 15 years. That's a pretty long time. And there's none that I know of that will be on the market anytime soon. I get email updates about this, and almost every week I'll get one about how there's a new study shows great results in dementia on 4 people or 7 people. And then a little less often, but still frequently, I'll get one about how large-scale trial for dementia medication fails. And I'll give you 2 examples of that here. Unfortunately, it's a tough place to be. People are somewhat desperate for a cure, and it would be fantastic if we had something. The government is now investing a ton of money in Alzheimer's research, and maybe with that impetus there will be something, but given the length of time between development and testing and market, I'm pretty confident that in the next couple of years there's not going to be a new pill on the market because as far as I know, it's not even in the pipeline. So this is just kind of a fascinating story about how this works and some of the economics of drug development. I wanted to give you two quick examples. The first one is called Dymabond. That's the brand name. The generic name is latropyridine. It had been sold over the counter, kind of like Benadryl here in the US. It's an antihistamine. People who did animal models indicated that it increased cognition and stopped cells from dying. So, maybe it will keep your cells alive. In Russia, they did a couple of double-blind, placebo-controlled studies, and when the people took this stuff, their score on a cognitive measure got better. So you notice those other graphs I showed, everybody got worse. At least in the long term. Here at 6 months, people improved, and then a year later, they were a lot better. So there's a piece that came out in July 2008 that said that this stuff shines as an Alzheimer's therapy. It's going to be the cure. The drug company Pfizer invested a ton of money to buy the rights to this so nobody else could take it. They were going to have it on the market in 2012. I remember just tons of hype about this. As they started their study, which was a huge study, 600 people at 63 different sites. So you can imagine the complexity. And doggone it, there were no difference in any of the endpoints they picked when they did a big multi-site study. And in fact, the people on placebo seemed to have a little bit better cognition in the long term. So just this drug that seemed to be so promising in phase 2 just fell flat on its face in phase 3. The little comment at the middle there nicely explains how a single bird doesn't make a summer and one positive clinical trial doesn't make a successful drug. Pfizer ended up writing off $725 million that they had invested. Once again, that could buy a lot of memberships in this lecture series. And somebody in retrospect, with the advantage of retrospect, pointed out that their drug really never had any benefit from the beginning, and that basically Pfizer had been sold a bill of goods with the whole concept that it might have a benefit. So an unfortunate but all too true story about what happens with some of these novel drugs. Here's another one that's even more timely. So this is straight off the website of a company called Axera that's making this drug, AC1204. This is still their main page as of a couple days ago. It talks about how this stuff works. It gets in there and fixes, I don't even know what those things are supposed to be. Ketones, maybe? Somebody may know what that is, little bits of gold in your neurons. And they claim an improvement in cognition has been consistently shown across multiple clinical trials. Here's their phase 2 results. Look at that. The people in the gray bars had an improvement in their cognitive skills. The improvement seemed to last. This all looks very promising as a cure. And then, once again, lo and behold, 6 weeks ago, they announced that their phase 3 study didn't demonstrate any statistically significant difference at 6 months. So once again, just didn't work when people looked at it in more detail, and they called it disappointing, but they still have hope that maybe if they use a different group of people or a different dosing, or if they could get more in the bloodstream, it might work. But this unfortunately is really emblematic. So if people ask you about, are there any promising drugs, there's a lot out there, but in terms of, materially finding something that works when subjected to scientific scrutiny, there's really nothing there. All right, so now let's turn to this issue of behavioral problems. And we talked about this in the first lecture, and I know you've had it covered in the other ones, that oftentimes people with dementia develop agitation, insomnia, delusions, aggression, repetitive behavior, all sorts of behavioral problems. And really the bottom line here is in this slide, that the number of FDA medications approved to treat these symptoms is 0, as in none, nothing, nada. It's not for lack of trying. I once went through and searched, for medication, behavioral symptom, dementia in PubMed, and came up with about 50 different medications that had been tried. Pretty much every class of medication None of them ever did well enough to merit an approval, which I think is a sign that they don't work. It's not a sign that somebody hasn't tried to do it, because there certainly would be a lot of money in selling something. And the consequence of that is that all medications used to treat such symptoms are off-label. They're just experimental, basically, without any clear scientific basis. The most common of these is antipsychotics, which have a very specific risk of death, so not a mild side effect. Just a reminder about what the antipsychotics are. This is like risperidone, olanzapine, quetiapine, Haldol, aripiprazole. So any of the medications that are in that class, typically used to treat schizophrenia. Sometimes people use them for other purposes, like augmenting antidepressants. In younger people who are agitated or delusional, they oftentimes have a significant benefit, like in the setting of schizophrenia. But unfortunately, in the setting of dementia, they don't really work that well, and also they have this very significant risk. So despite the fact that they have an increased risk of death compared to placebo, about a quarter of people in nursing homes with dementia are on one of these. This is just a reminder that this black box warning really does exist, and this is the actual text of the black box in case you happen to get a copy of the package insert for these medications. So 17 placebo-controlled trials, they all pretty consistently showed this increased risk of death compared to placebo of about 1.6 to 1.7 times. So not insignificant. If you're going to be prescribing a medication like this, you really need to give informed consent to people who are making the decision. And the goal is now, based on multiple professional recommendations, to use the lowest possible dose for the shortest period of time. Because if you continue to apply this treatment, people are going to be at risk of death. I think I showed this to you before, but for me, it's the way to make the most sense of this, that if you came up with a new treatment that reduced the risk of death by 38% in a group of people, this would make the front page of the newspaper. You would be hoping for your Nobel Prize because you had suddenly saved all these lives, and it would be seen as sort of a miracle. But in this case, the breakthrough or miracle would be to stop people's antipsychotics. Because based on the data and the black box warning, if you're on a pill, you're at about 38% higher risk of dying. And if you stop it, you'll be at a lower risk of dying. So it's really that simple, that some of these treatments that we're using are putting people at an increased risk of death. And you want to be pretty certain in that circumstance that if you're using the pill, you're getting some kind of benefit from it, instead of just giving the pill because somebody's got dementia and they happen to have been upset at one time. All right, let's turn quickly now to antidepressants and benzodiazepines, which deserve a brief mention. And this one is very commonly prescribed. I don't have the exact figures, but my guess is that about half of the people with dementia whom I see are receiving an antidepressant. It's not unexpected because people who have dementia oftentimes don't express the same level of interest. If you ask them how they are, they may say they're not doing well, and they may be irritable. So if somebody's younger and has those symptoms, we assume they may be depressed, and we'd want to give them an antidepressant. Unfortunately, antidepressants don't work very well in dementia. And in fact, they almost might not work at all. The jury is still completely out, but this recent review that came out of England, where they looked at all the studies that have been done of antidepressants in dementia, found no convincing advantage over placebo for the treatment of depression in dementia. That's a pretty strong, straightforward finding. They found no evidence for other benefits like cognition or caregiver burden, or psychosis or apathy. So it's not like you're helping other target symptoms. And their final take home is that we should question the use of antidepressants in dementia. So once again, this theme I'm trying to bring up, that medications, if you really look at them carefully, may not be providing that much benefit at all to people, and that we really should be asking ourselves, are we providing a benefit to folks? And if you put together what we were talking about before about the cholinesterase inhibitors or the dementia medications worsening depression, you can see that you could easily get into a vicious cycle here too, where somebody starts a medication for dementia, their mood worsens, they get started on an antidepressant, and you assume that they've got a primary depression, when in fact neither of the pills is really doing anything at all to help them. So this was eye-opening for me, because I had assumed, well, even if the antidepressants aren't working, sometimes we can take advantage of their side effects. So mirtazapine, which is Remeron, is a drug we frequently use in geriatric depression to help people who are having insomnia. It tends to put people to sleep. It's not addictive. It also helps them to gain some weight. And I had assumed that it would help people with dementia sleep, and had recommended this to lots of people over the years. And just last week I came across this study that when they really looked in a double-blind, placebo-controlled way to see if mirtazapine helped with sleep in the setting of dementia, nope, it did not. So pretty convincingly, it's not something that's going to help with even a problem or a symptom of dementia like insomnia. When you really step back, I think what you realize is that dementia involves a lot of changes in the brain, a lot of changes in the neurotransmitters, and that the pills that get in there and affect neurotransmitters don't work as expected. So if somebody's got depression without dementia, you can assume that they may have a benefit from an antidepressant. Somebody's got depression with dementia, it may be something very different, and the pill is just not going to work like you hope it will. Benzodiazepines, these are drugs like Ativan, Xanax, Valium, Klonopin, the generic names are down below, are often used for behavioral symptoms, or if somebody seems anxious. A study just came out last week about risk of pneumonia, and it looked like after they controlled pretty carefully that people who had dementia and received a benzodiazepine had a 30% higher risk of pneumonia, which is kind of a surprising finding, but once again points to these risks that may be there that are hard to see unless you look at a lot of data. The risk of falls is well known. And moreover, a lot of times these medications don't even work that well. And sometimes it's like giving somebody alcohol, where it ends up disinhibiting them instead of causing them to get more relaxed. So once again, a case of medications that are frequently used with good intentions, but may have significant long-term risks or drawbacks. So that's a rough overview of the medications that are specifically indicated for dementia, the ones that are used for behavioral symptoms but not approved since there are none, and then some of the other psychotropic medications. And I want to address now that another problem that arises because of the issue of the moving target. So given all this stuff I've been saying, your next question would be, well, why, if these things have risks and don't seem to help very much, don't people just stop using them? And in fact, lots of people do stop using them. If you really look at the prescription patterns, people come off of their dementia medications very frequently. One of the larger studies of this had a group that was supposed to stay on their donepezil, and half of them during the 1-year study decided to come off it, even though it was a recommendation. So people do discontinue. They vote with their feet and say, this stuff's not helping. But as a deliberate act, like a clinical decision, it's very difficult to stop medications. let me, before I lose the thread, I'll answer this question about benzo shown to have a higher risk of developing a type of dementia. There have been some epidemiologic studies indicating a higher risk of Alzheimer's disease among people who received benzodiazepines. Great question. That's a very cutting edge. That came out a couple weeks ago also. The paper that I cited about pneumonia was from Finland, and this Finnish group, I don't know how they're doing it, but they've got like 5 papers all of a sudden about risk of dementia and effects in dementia using this cohort of about 70,000 Finnish people. So great question. So yeah, benzos may have additional risks in terms of long-term effects also. So back on this issue of discontinuation. A problem with a disease that has changes and fluctuation and worsening is that oftentimes medications are stopped while somebody's having problems. So if somebody goes into the hospital, they'll look at the medication regimen, say, this is risky to give all these things, let's stop some of them. And then somebody leaves the hospital, and you'd say, well, he stopped the medication and he got worse. Or there's been a change in the caregiver and it's hard to keep up with the medications, and so you stop it and then the person gets worse, and you say, well, once again, you stop the medication and the patient's worse. And what you fail to recognize is that there was another event that happened that was the reason for the medication change. So it's very important, if you're assessing or measuring the effects of discontinuation, to do it in a planned and deliberate way. And I'm doing a study now of discontinuing cholinesterase inhibitors, and it's a tricky thing to do. It's hard to find people who are willing to be randomized to continue their pill